Okay, so we're picking up with chapter 16. We're in part 3 of chapter 16. We're going to start talking about the process of fertilization. So that secondary oocyte is really only viable for about 24 hours after ovulation. Again, different textbooks, different sources are going to tell you something different. This book is going with 24 hours. Really, that's kind of the peak. 24 hours is the optimum time for fertilization after ovulation. But that doesn't mean you can't get pregnant at other times in your cycle. It still is possible. The sperm are viable, as this book said, up to 48 hours after being delivered. So there also requires about 6 hours to move that sperm from the vagina to the uterine tube. So sperm delivered up to 2 days before ovulation will ultimately have the best chance of fertilizing the egg. So the semen are delivered into the vagina near the cervix. It's going to coagulate and kind of clump together. After 10 to 20 minutes or so, a special enzyme called PSA, prostate-specific antigen, other enzymes are going to cause that semen to reliquefy and kind of declump almost, and prostaglandins are going to increase the motility of the sperm so they can move well. They're going to swim through the vagina, through the cervix, up to the uterine tube. Ovulatory, late post-ovulatory phase, mucus is very thin, very watery, very easy to penetrate, as opposed to the pre-ovulatory mucus, which is very thick. If the sperm pass through the mucus of the cervix, they're going to swim along the walls of the uterus into the uterine tubes. Uterine contractions help the sperm travel. There's capacitation of sperm, which is going to occur at this point. Capacitation is activation of the sperm. This is going to allow the sperm to actually fertilize that secondary oocyte. The sperm motility increases, the acrosome is stripped of all of its extras, and the enzymes in that acrosome are allowed to digest through that special shell called the corona radiata that surround the egg. This animation goes through the process of fertilization. So let's talk about the process of detecting ovulating. How do you know when you're ovulating? Well, unless you're one of those females that sits down and writes down every single day of her menstrual cycle, you might not know when you ovulate. Even if you do write down every single day of your menstrual cycle, you still might not 100% know when that day 14 is occurring, because everyone's cycle is slightly different. So ovulation tests are detecting high levels of luteinizing hormone. They can predict ovulation up to 1 day in advance. They're also going to detect your basal body temperature. Right before you ovulate, your body temperature decreases drastically. I say drastically, it's about a ½ degree, which is actually pretty drastic if you think about how our body maintains a stable temperature at all other times. So very sensitive basal body temperature thermometers can be used to estimate ovulation as well. So let's talk about the process of contraception. This is, of course, preventing fertilization or interrupting the fertilization process. A lot of people like to practice sexual intercourse without having the results of a baby. All this time we've been talking about how our bodies are preparing us to make babies, but not always is that the case that you actually want to make a baby. So that's when contraception comes into play. Abstinence, of course, is the best way to not get pregnant, just avoiding sexual intercourse in general, which sometimes is not the desired outcome of a relationship for many of us. You can block the travel of sperm or egg. So sterilization is one way of doing that. Having a vasectomy in males, where literally a portion of that vas deferens is removed. The sperm are still produced, but it doesn't go anywhere. They just kind of swim around in the testes and then eventually die. Females can have a procedure called a tubal ligation, where the uterine tubes are tied, closed, and then they're cut. The secondary oocyte is still produced, but it can't pass through the uterine tubes because they're cut. There's also hormonal preventatives. There's oral contraception that can vary estrogen and progesterone levels. There's negative feedback inhibition of FSH and LH. There's also prevention of dominant follicle development. So there's different types of hormones females can take to interrupt their cycles. There's also preventing the sperm from accessing the uterus and uterine tube. So this would be barrier methods like a condom, a vaginal pouch, or a diaphragm. There's also spermicides, which are special creams or foams or suppositories which kill the sperm. There's also ways of preventing the implantation of a fertilized egg. So intrauterine devices would make the uterus impossible for a fertilized egg to implant. There's also the emergency contraceptive or morning after pill, Plan B. This term is kind of controversial. It's not really a non-surgical abortion. It's not going to prevent a pregnancy if pregnancy is already there. In other words, if the egg has already implanted, if the fertilized egg has already implanted, the morning after pill is not going to de-implant or abort the baby. However, if fertilization did occur, it will prevent its implantation. So it's going to block progesterone, and therefore the endometrium is going to degenerate, not allowing for that fertilized egg to attach. So these are just going through some different ways. Again, you have the various procedures that can occur in a male or a female. Again, notice the majority of these are all in the female. The tubal ligation, the hormonal methods, lots of the barrier methods, including the diaphragm, spermicides, intrauterine devices, are also for use for females. Some of them look kind of scary. Let's talk about sexually transmitted diseases. These are STDs, can be caused by bacteria, viruses, protozoa, or even fungi. Very common STDs include chlamydia, usually no symptoms, could cause a little bit of painful urination in males, maybe some pelvic inflammatory disease in females, but there's very few symptoms with chlamydia. It's treated with antibiotics. There's also gonorrhea, also treated with antibiotics. Painful urination, maybe a pussy discharge. It can be symptomless in females and eventually lead to sterility. Syphilis is symptomatic when there's a painless open sore on the genitals. There can be a rash or a fever, maybe some joint pain associated with the onset of syphilis. Ultimately, very debilitating. It is treated with antibiotics, but organs can deteriorate. It can lead to system failure at the body level. There's also genital herpes, which is painful blisters on the external genitalia. There could also be internal blistering in females. This is controlled with special anti-inflammatory drugs. Since it is caused by a virus, there's no actual getting rid of herpes. You'll always have it once you get it. Genital warts are a cauliflower-like growth on the external genitalia. It can also grow inside of females. The warts can be removed cryogenically by freezing them off. As you can imagine, much discomfort caused by those STDs. Not an STD, but sometimes an unwanted effect of intercourse would be pregnancy. Usually lasts about 38 weeks. 36 to 40 weeks is the norm, although 40 weeks is technically the duration of pregnancy. The due date is calculated from the first day of the mother's last menstrual period, which you may know if you've ever been pregnant before. The fertilized egg reaches from 1 cell to 1 trillion cells during those 38 weeks. The embryonic period is the first 8 weeks, and then the fetal period is 8 weeks on. So the first cell that is formed when the oocyte is fertilized is called a zygote. In that zygote are the 46 chromosomes that make up that new life. It's 23 from the egg and 23 from the sperm. Then you have cleavage. Cleavage is the mitotic divisions that occur during those first 2 days after fertilization, making progressively smaller cells, because that oocyte was a very, very large cell, eventually form something called a blastomere. A morula is a solid sphere of cells. This occurs about 4 days after fertilization. It's surrounded by a zona pellucida, which is a nice clear kind of sugar protein layer. This is continuing to move through the uterine tube down into the uterine cavity. Once it gets into the uterine cavity, there's special cells that are going to activate, forming a hollowed out cell called a blastocyst. This blastocyst is produced about 5 days after fertilization. It's a hollow ball. It has a tropoblast, which is going to form the placenta, and then an inner cell mass, which forms the embryo. At this point, it's made of hundreds of cells, but it's still the same size as that original fertilized secondary oocyte. It floats freely in the uterine cavity for about 2 days before it finds a nice good home inside the uterine wall. So up to 7 days after fertilization occurs, this blastocyst still hasn't implanted. The blastocyst itself, as I said, is that hollow ball made of the inner and outer cells. Outer cells are going to form the placenta. Inner cells are going to make up the embryo. Made of hundreds of cells, freely floating, as I mentioned. Implantation usually occurs on day 6 after fertilization. And just to keep track of everything that I've been saying, remember, optimal fertilization time is to have intercourse 2 days before ovulation. So if you had sex 2 days before you ovulated, and this is 6 days after you ovulated, we're talking more than a week between the time that you had sex and the time that implantation is actually occurring. So this is why pregnancy tests aren't immediate. This egg still has not implanted, so your body still hasn't completely become aware that there is a new life growing inside of you. The blastocyst is going to attach to that uterine lining. That inner cell mass is orientated toward the endometrium. So here you see this whole process of fertilization, 12 to 24 hours past ovulation. Then you have cleavage, those first sets of division forming from the zygote into the blastomere. And then you have a morula, which is a very thick ball of cells. Notice the size. This size is the same as this size. And then once that morula reaches the uterus, it hollows out, forms an inner cell mass and this outer tropoblast. That tropoblast is going to eventually form the placenta. This inner cell mass is eventually going to form the embryo. So, during the second week, I should say, of embryonic development, you have chorionic villi formation. These are little finger-like projections going into the uterine tissue. This is going to form the basis of the placenta. Oxygen and nutrients in the maternal blood are going to diffuse into the capillaries of these chorionic villi. Waste from the chorionic villi are going to diffuse into the uterine capillaries. The embryo is going to begin to secrete HCG, preventing the destruction of that corpus luteum, allowing for that continued secretion of estrogens and progesterones to maintain the uterine lining so that menstruation does not occur. During week 3, the process of gastrulation occurs. Gastrulation is when the cell, this little ball of cells, finally says, okay, this area is going to become the skin. This area is going to become the connective tissues. This area is going to become the nervous tissues. So it's the first process that occurs in differentiation. The inner cell mass divides into 3 germ layers: the ectoderm, the mesoderm, and the endoderm. The ectoderm is going to form the nervous system and the skin. The mesoderm is going to eventually form connective tissues and muscles. And the endoderm is going to form the GI tract, the respiratory tract, the urinary tract. Neurulation is occurring during week 3, and this is when the notochord is formed. This is a flexible rod of that mesoderm, eventually forming those intervertebral discs, the spinal cord, our backbone. It's going to trigger the underlying ectoderm to form that neural tube and eventually form the nervous system, the spinal cord. Also during week 3, you have the placenta and umbilical cord beginning to form. The placenta, of course, is the site for nutrient exchange. Umbilical cord connects the placenta to the embryo. The embryonic body is surrounded by a thin membrane called an amnion, which fills with fluid. The amniotic fluid acts as a shock absorber, helps to regulate temperature, prevents desiccation, in other words, drying out, and it also prevents adhesions of the skin of the fetus and other tissues. So it prevents the fetus from sticking to anything. Here you can see this is at does not say how long. This is not a 3-week embryo or 3-week fetus. if I had to guess, I would say this is around 8 or 9 weeks, just because of all of the features that we see here. Still very, very, very small. And you do see the chorionic villi kind of extending into the endometrium, forming the basis of that placenta. So from weeks 4 to 8, the size of the embryo almost triples during that 4th week. Week 5, there's lots of precursors for male and female reproductive systems, hormone regulation, sex-specific structures. The males are going to start secreting testosterone. Females have an absence of testosterone, so the male precursor organs are going to degenerate. By the end of week 8, all major body systems develop, but their functioning is minimal, but all of the groundwork for all of the systems are there. By the end of this period, we no longer call the fetus an embryo. It's now a fetus. The fetal period is beginning at week 8. So here you see a 20-day-old embryo. Again, you really just see a big ball of cells. You can make a little bit of this neural groove where the intervertebral disc and spinal cord are going to form. A 24-day-old embryo. Again, it's nice and long, but you can see how you have a little bit of a swelling up here, which will eventually become the head and the brain, a heart in this area. And if you were to look at a live footage of this, you would see it flickering. Those cardiocytes flicker very, very early in development. And you can see the beginnings of that spinal cord right here. Kind of an awesome thing, I think. 32 days. So again, we're into week 4 almost, and this is what we have. Still kind of looks like an alien structure, but you do have a head region. These are not arms. In fact, these are gills, which will eventually obviously disintegrate through development. But you see this heart prominence looks very odd, but eventually tissues will grow around it, so you can't make that out anymore. You can see the buds of limbs, and of course a tail. Humans had a tail in utero. At 44 days, so here we're almost at 8 weeks or so, see a very alien-shaped head, but that's because the brain is growing at a very rapid rate. You can see the beginnings of an ear, beginnings of a nose, upper limb. You can almost see all those fingers forming there. Lower limb. Look how large this umbilical cord looks compared to the embryo. At 52 days, you can see here we have eyes, nose, ears, limbs. Very, very cool. Umbilical cord. So after week 9, that we now call the baby a fetus, the tissues and organs are going to continue to grow until about the last 2.5 months before birth. Half of the full term weight is then added. So the last 2.5 months are really time of huge growth for the fetus. Fetal limbs are going to increase in size. The head is going to go from half the length of the body to just 1/4 of the length of the body. So in other words, the proportions are going to change. The external genitalia, internal reproductive organs, will have developed. The fetus is less impacted by drugs, radiation, and microbes compared to an embryo. Doesn't mean that you can drink, doesn't mean that you should drink. It just means that if you happen to come in contact with some type of toxin, it would not be deadly. Here's the 10-week-old fetus. So my approximation, that last diagram was pretty good. I said 8 weeks. You can see an eye, large head. Again, you can make out that brain in there. Very, very cool. This is the heart, almost consuming the entire abdominal cavity, which of course we know that it doesn't. You can see the lower limbs there. Very, very cool. A 13-week, then you get to a 26-week. Look at that difference. 26-week. Most sonograms will occur at around 20 weeks or so of gestation, and that will be the big sonogram to determine the gender. And you can tell maybe at this, of course the legs are kind of in the way to see any external genitalia, but it would be very indiscernible at this stage. But at 26 weeks it would be very discernible to tell whether or not you have a male or female fetus at this time. So let's talk about fetal blood flow. The blood flows through vessels to and from the placenta chorion. There's scant amounts of blood sent through the pulmonary circulation because there's not a lot of function to the lungs at this point. The baby's sitting in a big water balloon, so there's no use for the lungs in utero. At birth, those placental vessels and vascular pathways are bypassed, and the pulmonary circulation is then implemented. Within a week after birth, the circulatory pattern is established. So this animation here goes through embryonic and fetal development. Let's talk about changes in the mother, changes in maternal physiology during pregnancy. In the end of the 3rd month, the uterus occupies the majority of the pelvic cavity, extends into the abdominal cavity as that fetus continues to grow. The fetus is exerting extensive pressure on the diaphragm. Most women have trouble breathing, the liver, the intestines, the stomach, lots of GI problems in pregnant women. 38 weeks is technically considered full term. There's also changes to the skin. There's increased pigmentation around the eyes, on the cheeks, around the areola, in the lower abdomen. There's stretch marks that can occur as the fetus grows and your skin stretches. You could suffer hair loss. The cardiovascular system changes because there's an increase in blood volume, so the stroke volume is going to increase. Because your stroke volume increases, your cardiac output increases. Because you have increased maternal blood flow to the placenta, an increased metabolism because you're growing another human being inside of you. All of the above are increased to meet the oxygen and nutrient demands of the fetus. You also have changes in the pulmonary system. Your total body oxygen is going to increase by 10 to 20%. It's also higher difficulty breathing as that fetus grows because the uterus is pushing on the diaphragm. There's also changes in the digestive system. Most pregnant women will have an increase in appetite, but actually be able to eat less because the baby is just taking up so much room in the abdominal cavity. There's pressure on the stomach, which can lead to heartburn. There's also a decrease in GI tract motility, leading to constipation, a longer time before gastric emptying, nausea, vomiting, and heartburn, as I mentioned. There's also urinary system changes because of the pressure on the bladder, causing increased frequency and urgency of urination, as well as stress and incontinence. There's also reproductive system changes. There's edema or swelling of the vagina, increased blood flow to the vagina, increased numbers of muscle fibers in the uterus, enlargement of the uterus, obviously it's growing a baby, and increase in the mass of the uterus. Other physiological changes include weight gain due to fetus, amniotic fluid, placenta, uterine enlargement, increased total water concentration in the body, increased nutrient storage, enlargement of breast for lactation, as well as lower back pain because of all of that extra weight that's being put on the front of the body. So some important hormones in pregnancy. HCG, which we've mentioned, secreted by that chorion, maintaining that corpus luteum. It peaks at about the 4th month of pregnancy. There's estrogen and progesterone, which are secreted initially by the corpus luteum and then later on by that chorion throughout the rest of pregnancy. There's relaxin, which is secreted by the corpus luteum and eventually the placenta. Helps to soften the pubic symphysis, to relax the sacroiliac ligaments, to help enlarge the pubic outlet for delivery. There's also HCS, which is human chorionic somatotropin. I can't say it right now. It's too late right now for me to pronounce that. HCS is all you need to know. It's secreted by the chorion. The secretion is going to increase as the placenta grows. It peaks at about 32 weeks of pregnancy. This hormone is going to help prepare the breast tissue for milk production and lactation. There's also CRH, which is corticotropin releasing hormone. This begins to be released by the placenta at about 12 weeks of pregnancy. It increases until the end of pregnancy, and this is important for the timing of the birth process. So in other words, it kind of times your gestation period. This animation here goes through hormonal regulation of pregnancy. This diagram here is showing you just how big that baby gets. All the way up, pressing on the diaphragm. Look at where the intestines are. They're just kind of wherever they can squeeze. You have a stomach over here. You have a liver kind of squeezed up here. And then, of course, you have a little bladder down here. So lots and lots of conformational changes in a full-term pregnancy. The process of labor. This is the process of giving birth. The fetus is expelled from the uterus through the vagina. Estrogens are going to stimulate the placenta to release prostaglandins. Prostaglandins help to induce enzyme secretions to break down the cervix. The cervix is therefore going to soften. As that cervix softens and ripens, as they say, the baby can fall down into that canal a little easier. Estrogens are going to induce oxytocin in the uterine muscles. Relaxin is going to increase the flexibility of the pubic symphysis as well as aid in cervix dilation. Labor is an example of a positive feedback loop. The uterine contractions induced by oxytocin cause the cervix to stretch. Stretching of the cervix is going to cause uterine contractions, which cause the cervix to stretch, and so on and so on and so forth until the baby is born. Here you see that positive feedback loop. You have the contractions on the walls of the uterus, forcing the baby's head into the cervix, stretching the cervix. Stretch-sensitive receptors are going to send impulses to the brain to release oxytocin. Oxytocin is going to make your uterus contract. Uterus contracts is going to cause stretching of the cervix, so on and so forth, until eventually the cycle is interrupted by the birth of the baby. And you might hear my baby crying on the baby monitor. But it is very late right now. It's like 1 in the morning, so I'm going to let her fuss for a minute. So let's talk about the 3 stages of labor. There's the dilation stage. This is when the cervix dilates for the baby to pass. It says lasts from 6 to 12 hours, but if you talk to anyone that's had a baby before, they might tell you, oh, I had it in 2 hours. Oh, I had it in 48 hours. So it really depends on the woman. This is regular contractions of the uterus, the rupturing of the amniotic sac, and the complete dilation of the cervix. So the dilation stage is basically how long you are laboring for. Then you have the expulsion stage, when the baby is actually coming out and being expelled. This can last from 10 minutes to several hours to 30 seconds, depending on the size of the baby and the woman's anatomy and all the other complications that could occur. Then you have the placental stage, because it's not just a baby that's being delivered, it's also a placenta that's being delivered. The placenta, or afterbirth, is expelled by uterine contractions naturally after the baby is born. Contractions are then going to constrict the blood vessels that are torn during delivery to reduce any hemorrhaging that may occur. Here you can see the process of dilation, exactly what is dilating here. The tip of that uterus, which used to be kind of like the neck of a beer bottle, and now it's more like the mouth of a mason jar, shorter and wider. And then the baby comes out in the process of expulsion, and then the placenta detaches and is expelled as well. Parturition is the act of giving birth. It's the technical term for delivery. Labor lasts longer with the first baby, typically around 14 hours. Then you have the afterbirth, or rather after the first birth, parturition tends to be shorter. Your body tends to respond to the signals a little bit better the second time or third time or fourth or fifth time around. The fetus is usually positioned head down toward the vagina. Any other orientation is known as breech. For delivery, the fetus could be turned manually, or the doctor may decide to deliver you via C-section or cesarean section. This animation here goes through the regulation of labor and birth. Let's talk about premature infants. Premature infants weigh less than 5.5 pounds at birth. They usually need medical care to survive. Their body may not be adequately developed. Premature delivery can be caused by poor prenatal care, drug use by the mother, history of previous premature deliveries, or a young mother or an older mother, so under 16 or over 35. Delivering past due is a common theme also. 7% of women actually do not deliver by 2 weeks after their due date, or 42 weeks. This could be an inadequate supply of oxygen and nutrient from an aging placenta is going to increase the risk of brain damage and fetal death. So delivery can be facilitated through oxytocin. The synthetic form of oxytocin is called Pitocin, which you may have heard of before, or a C-section. Along with labor and delivery, after you have that beautiful baby, now you're going to lactate. It's a natural process. The prolactin hormone maintains milk production by the mammary glands. Milk is produced after birth, after inhibitory levels of estrogens and progesterone are removed. Sometimes lactation occurs during pregnancy, and that's just, again, your body's response to hormones. Everybody's different, and their responses to hormones are different. Lactation is another example of oxytocin positive feedback. You have the suckling, which is going to cause oxytocin to be released from milk ejection, which encourages more sucking, which encourages more milk ejection, and so on and so forth. The mechanism goes from the special glands in the mammary glands all the way up to the hypothalamus and anterior pituitary. It's a positive feedback loop, as I mentioned. So the sucking of the baby or the sucking of your breast pump is going to cause the touch sensations to send information to the sensory neurons to tell the posterior pituitary and hypothalamus, get the contraction cells of your mammary glands going to get the milk ejection. Colostrum is the nutrient-rich fluid secreted from the mammary glands the first few days after birth. It's less lactose and no fat compared to milk. It has a very high protein content, lots and lots of antibodies being the source of adaptive immunity. It's readily digested until the true milk comes in about 4 days after birth. So that's another common misconception with breastfeeding, and that is that as soon as you give your baby, your milk is there. Some women take up to a week for their milk to come in. Just keep nursing and your milk will eventually come in. Lactation is the frequent sucking 8 to 10 times a day. It can block ovarian cycles. So in other words, if you're exclusively breastfeeding a newborn, you may not get your period for a number of months or maybe even years, depending on how long you breastfeed for. It's not a reliable form of birth control, but because of that oxytocin letdown reflex, it can block those ovarian cycles. The primary benefit of breastfeeding is nutritional for your baby. Human milk is sterile. It's kind of a gross idea to some people that it's a body fluid, but it is a sterile natural chemical or natural substance produced by our body. It's actually ideal for infant digestion as well as their brain development and growth. It has more nutritional value than synthetic formulas. Most synthetic formulas on the market try to be as best they can like breast milk. It contains fatty acids, lactose, amino acids, vitamins, minerals, water, as well as antibodies from the mother. Typically, a breastfed baby is the healthiest person in the house. Even if your baby is exposed to lots and lots of germs, cold and flu, etc., more than likely, if you're breastfeeding your baby, they're going to stay healthy even through the cold and flu season. Maternal benefits of lactation are present also. There's weight loss more quickly than if not breastfeeding because of the excess work your body has to do to produce the milk. There's typically less postpartum bleeding as well. The uterus returns to pre-pregnancy size much more quickly because the oxytocin released for the letdown is going to cause your uterus to contract back to size. It can also reduce the risk of breast and reproductive organ cancers. This animation here goes through the regulation of lactation. So let's talk about aging and reproductive capacity. Of course, the reproductive system in juveniles doesn't work. It's non-functioning. It's kind of just there for future use. Neither male spermatogenesis or female reproductive cycles occur during childhood. At puberty, sometime between the ages of 10 to 14, again it varies based on genetics and nutrition, there's small bursts of GnRH from the hypothalamus stimulating FSH and LH, going to stimulate the secondary sex characteristics, stimulate the onset of menses in females, and stimulate spermatogenesis in males. Young and early adulthood, ages 15 to 40, both genders are fully capable of reproduction. Around middle age, 40s into 60s, females tend to have a shrinking number of viable follicles and will eventually go into menopause, which is the cessation of menses. Most healthy men are still capable of reproduction. Some may have a decline in testosterone and sexual desire. elderly, 69 or older, as definition by this textbook. Males are reproductively capable into their 80s and 90s, but they may have reduced muscle strength, fewer sperm, and decreased sexual desire. And females who are in menopause are no longer capable of reproduction. And that concludes chapter 16 and this course.